Hi friends, today I'll be speaking on Fascia Iliaca compartment block. The images which I have taken are from Nicera internet and I have obtained the patient consent. No disclosures. Now coming to the innervation of the lower limb, as you can see, the lower extremity innervation is provided through four major nerves, that is the sciatic nerve posteriorly, the femoral nerve, the obturator nerve, and the lateral cutaneous nerve of the thigh. The femoral nerve, the obturator nerve, and the lateral cutaneous femoral nerve all arises from the lumbar plexus. Sciatic nerve originates from the lumbar as well as the sacral plexus. Hence, it's called lumbosacral plexus. Now, if you see the innervation in terms of dermatomes, myotomes, and osteotomes, the major nerves anteriorly is your femoral. It's the largest branch of the lumbar plexus. Okay. And after supplying the skin, anteromedial surface of the thigh and the medial aspect of the lower limb, ankle and foot in its terminal branch, that is the saphenous nerve. The obturator nerve is motor to the hip adductors, okay, and sensory to the skin just above the knee joint medially. And for the osteotomes, if you see, the majority anteriorly is by the femoral and the hip and the knee by the obturator and posteriorly by the sciatic. The major muscles is supplied by the femoral, okay, and the hip adductors by the obturator. If you see, the femoral is the largest branch of the lumbar plexus originating from the posterior divisions of anterior rami L2, 3, 4, descends through the posterior 1/3 of the psoas major muscle, emerging from its lateral border and continues caudally between the bulk of the psoas major and the iliacus muscle here, enters the thigh behind the inguinal ligament lying lateral to the femoral artery and on top of the iliacus muscle, separated from the artery medially by the fascia iliaca. Okay. The obturator nerve originates from the anterior divisions of the L2, 3, and 4 rami, descends with the psoas major muscle, emerges at its medial border behind the common iliac vessels, lateral to the internal iliac vessel, and enters the thigh through the obturator foramen here and divides into the anterior and the posterior branches. Then comes the lateral cutaneous nerve. Okay, it arises from L2 and 3, emerges from the lateral border of the psoas major muscle, runs on the ventral surface of the iliacus muscle, heads towards the anterior superior iliac spine, okay, behind the inguinal ligament. At its insertion to the anterior superior iliac spine, it emerges outside and divides into two branches, anterior and posterior branches at this junction. Okay. Now, fascia iliaca, what are the approaches to the femoral nerve? So you can approach, if you see the course of the femoral nerve, you can approach it supra-inguinal, superior to the inguinal ligament, that is the supra-inguinal approach, inferior to the inguinal ligament, that is the infra-inguinal approach to the fascia iliaca compartment block, then the classical traditional femoral nerve beyond the inguinal crease, and after it supplies the motor branches where it lies at the adductor canal and then continues forward as the saphenous nerve. At the adductor canal, you can block the femoral nerve, that is the saphenous nerve. The fascia iliaca compartment is also known as the anterior approach to the lumbar plexus. The fascia iliaca compartment is a potential space lying between the fascia iliaca anteriorly, the iliacus and the psoas muscles posteriorly. The fascia iliaca attaches to the iliac crest here laterally and to the fascia overlying the psoas muscle, okay, medially. Posteriorly to the external iliac vessels and anteriorly to the lumbar plexus. Okay. Distally, it invests the femoral nerve and passes posteriorly to the femoral artery and vein, the vessels which lies in the lacuna vasorum. Here is a cadaveric picture where you can see the iliacus muscle. This is the fascia iliaca compartment, suprainguinal compartment and infrainguinal compartment. Okay, showing the boundaries very nicely here. You can see that the fascia iliaca going over the femoral vessels. Okay, and this is the femoral nerve. Okay, which is further away from the vessels suprainguinally. Okay, whereas infrainguinally you can see how the nerve runs along the vessels. Now, after knowing the boundaries, you can see that the fascia iliaca, this is a pictorial representation showing the fascia iliaca compartment and the three nerves, that is the lateral femoral cutaneous nerve, the femoral nerve, and the obturator nerves here. They are in a continuous compartment, but you can see the difference that the obturator nerves are separated from the femoral and the lateral femoral cutaneous nerve by the psoas major and the pectineus muscle. And hence, though placement of LA drug in the fascia iliaca compartment can block all the three nerves, the obturator nerve, because it's far away from these two, it may not be always blocked in the fascia iliaca compartment block. Also, you can notice that in the compartment also lies the genitofemoral nerve. So genitofemoral, which runs in the anterior aspect of the psoas muscle, posterior to the fascia iliaca, mostly gets blocked in the fascia iliaca compartment block. Coming to the history, Vinny et al. In 1973 showed us a landmark guided 3-in-1 block for the first time. Dellens et al. In 1989 showed us a landmark guided infrainguinal fascia iliaca compartment block. That is a classical approach. Dellens et al. In 2006 showed us the USG guided fascia iliaca compartment block. Stevens et al. In 2007 showed us a landmark guided suprainguinal fascia iliaca compartment block, and Hebard et al. Showed the same using USG in 2011. What are the indications? Any sort of fracture femur, fracture neck of femur especially, in the perioperative or post-operative analgesia, or even if you increase the concentration of the drug, you can give anesthesia too. Therefore, it can be used at the accident site while transportation or as an on-arrival block for pain relief. It can also be used to give pain relief so as the patient can give position for your spinal or epidural. Minor surgeries in the extensor compartment of the thigh, adjuvant anesthesia for about knee amputation, knee surgery in conjunction with sciatic nerve block, it can give a complete anesthesia too. Contraindications is the patient refusal, infection or inflammation in the region of the block, that is the groin, allergy to local anesthetic agents, certain skin conditions in the groin, septic arthritis of the hip joint, or previous femoral bypass surgeries, that is femoral vessel bypass surgeries, it is contraindicated. Advantages: it gives excellent, good compartment nerve block from hip to knee. Significant reduction in the requirement of morphine was noticed. Reduced rates of deep vein thrombosis because of early mobilization post-operatively. And the block also reduced the delirium and cognition impairment because of excellent pain relief, especially in the elderly with fractured hip. It is extremely low skilled, inexpensive, and effective technique. Just the right attitude to give the block is needed. Landmarks. Here the landmark is bony landmark is the pubic tubercle and the anterior superior iliac spine. These are the two landmarks which even in the obese patients you can feel it very nicely. Draw a line from the pubic tubercle to the anterior superior iliac spine, that is the inguinal ligament, and around 2 centimeters below lies your inguinal crease. Now divide the inguinal ligament into 3 equal parts. Okay. Now where is your point of needle entry is? That is at the lateral 1/3 and medial 2/3 junction of the inguinal ligament. Just few millimeters or 1 centimeters beneath that lies your point of needle insertion. You can keep your 2 fingers, make 2 V, okay, with both the hands. Keep 1 finger at the anterior superior iliac spine and 1 at the pubic tubercle. You get equal 3 parts, okay, and lateral 1/3 and medial 2/3, just beneath that, above the inguinal crease, is your point of needle insertion. At this level, you are very much far away from the femoral artery and vein. Okay, so you are very safe. You can always palpate and check whether you are far away or not. What are the equipments? Sterile gloves, sterile gauzes, povidone iodine or chlorhexidine for skin preparation, 2% xylocaine plain for local infiltration, because you are going to use blunt needles. It will be very painful, therefore better to give local. You can either use bupivacaine or ropivacaine, 20 cc syringe, and the hypodermic needle, that is 21 gauge hypodermic needle, 1.5 inch of length, which comes along with the 20 cc syringe, is easy to use. You can also use the Stimuplex needle, 5 centimeters, which comes along with an injection port, and blunt tipped 22 gauge. Technique. It is good to use, explain the, good to take consent, explain the procedure well to the patient. Do it under all aseptic precautions. Assistant is mostly needed when you're using an injection port, so that you can keep the needle and the assistant will inject the LA drug. And also when the patient is obese with pendulous abdomen, the assistant can retract the abdomen away from the side for you. Patient is in supine position with legs slightly abducted. 21 gauge hypodermic needle can be used. Also, Stimuplex or epidural needle can be used. The fascia lata and fascia iliaca forms the basis of this block. Hence, you have to remember is bounce, pop, bounce, pop. That is 2 bounces and 2 pops. The first bounce and pop is of the fascia lata. As the needle goes beneath the skin, the subcutaneous tissue, you get the first pop, that is of the fascia lata, and then you get the second bounce and pop, that is of the fascia iliaca, when you further advance the needle to enter the fascia iliaca compartment space. Now I'll show, keeping this in mind, I will show the video. You can see that the pubic tubercle and the anterior superior iliac spine is marked. At the point of needle entry, see, again I'm assuring, go bang perpendicular after giving the local. This is a blunt 22 gauge stimuplex needle. You see the bounce and the pop. That is the first bounce and pop of fascia lata. This is the second bounce, second pop. That is the fascia iliaca, and aspirate and inject into the fascia iliaca compartment space to get a good fascia iliaca compartment block. Now, when you want to use a hypodermic needle, you have to blunt the tip. So you can do that by tapping the needle tip on the sterile surface. This is the straight needle. This is the needle after blunting it. You can see that the tip looks like a parrot beak here. This is a video showing how I'll be using 21 gauge hypodermic needle that comes along with 20 cc syringes, or you can get a 1.5 inch needle, tapping on the sterile surface. Once or twice is enough. Now the needle tip is blunted or bent, but the sides of the needle is still sharp. Feeling for the anterior superior iliac spine and the pubic tubercle. Make 2 V. You can see the inguinal ligament line and the inguinal crease here very nicely. Now, see very nicely, the inguinal ligament is divided into 3 parts, and at the junction of the lateral 1/3 and medial 2/3 is your needle entry point. Now the blunted needle is used. Remember, the tip is blunt, so it won't enter. So how will you enter is at the through the sharp edges at 45 to 30 degrees. You pierce the skin, enter, and then you make it perpendicular. That is your first bounce. Go further. You'll get the first pop, that is the fascia lata is pierced. Then you got the second bounce and second pop, that is the fascia iliaca is pierced. Now you take the LA drug, hold the needle carefully, aspirate and inject. After every 5 cc aspirate and look for free flow of drug coming back through the needle. See, you can see the free flow. That means you're not in the iliacus muscle and you are in the compartment. If you're in the iliacus muscle, you need to withdraw the needle a little bit outside. You can see the free flow of the. Now, total 30 to 40 ml of LA drug has been given after repeated aspiration and checking for free flow of the free backward flow of the drug. Okay. The remaining of the drug is injected. Now coming to what is the effective volume to get an effective block. Okay, it has been described as the volume which will give good block of all the 3 nerves lying in the fascia iliaca compartment. In the classical fascia iliaca compartment block, the volume was described as 30 to 40 ml. So many studies have been done and they have found that the effective volume to block 50% good block is around 28.79 ml for ropivacaine and 29.5 ml for bupivacaine. To get 95% effective block, it was around 34 ml for ropivacaine and 36 ml for bupivacaine. And to get 99% block, that is 36.6 and 37.3 ml for bupivacaine. Hence, it was seen that the good effective block volume, the average dose is around 36 to 37 ml. That means as you increase the volume, the efficacy of the block is also increased. Okay, and in the suprainguinal approach, that is when you enter the fascia iliaca compartment block above the inguinal ligament, they have seen more cephalic spread, more effective block with lesser volume. So minimum to get 50% effective block was around, minimal volume was around 15 ml, and to get 95% block, the volume was around 27 ml. You have to keep this in mind. To get effective volume, you need around, even this averages around 30 ml. So it will be nice if you can give around 30 to 40 ml. Limitations include inguinal innervation. You have to understand the area around the anterior superior iliac spine is supplied by the subcostal nerve. Sometimes for a fractured femur, they need to do a percutaneous nailing and they go higher up. So it is not the block which is inadequate. The innervation is by the subcostal nerve. Therefore, you need some local infiltration around this area. Also, in the just at the groin, the innervation is by the ilioinguinal nerve and the genital branch and the genitofemoral branches here. So you need to block them separately. Especially this is seen when you have some skin conditions or skin infections, debridement, skin grafting, or some abscess or some lesions, inguinal node and all. So you have to remember that this needs to be blocked separately. Coming to the last slide, that's the pearls. Find the landmarks carefully. They are the anterior superior iliac spine and the pubic tubercle. The fascia lata and the fascia iliaca are the two most important thing which forms the basis of the fascia iliaca compartment block. Hence, you have to feel for the bounce pop of as the needle pierces through the fascia lata and the fascia iliaca. If there is any resistance during the administration of the LA agent, or if there is no backflow of the drug, slowly pull the needle a little bit outside and try administrating the LA agent again. You might be into, the needle tip might be in the fascia iliaca muscle. This is a volume dependent block. Say for large volumes are required to achieve good analgesia, usually around 30 to 50 ml. Therefore, you have to calculate the drug concentration and dosage as per the patient's weight. You can add additives like Dexa. 8 milligram Dexa is far superior to 4 milligram. You can easily use 8 milligram Dexa for long acting. You can achieve around 36 to 48 hours of good analgesia. Clonion can be added, dexmedetomidine can be added, and even Maxilf has been added by many. But addition of one single adjuvant is enough to get good prolonged analgesia. The placement of manual pressure inferior to the injection site can be done so that the local anesthetic agent can flow cranially. Okay. In all, fascia iliaca compartment block is a volume dependent block, very easy, just a needle and syringe filled with LA is required. So I hope I have explained well. Thank you. Thank you all.